chronic lymphocytic leukemia. We aim to learn definition, demography, etiology and pathogenesis, diagnosis, and management. CLL is a blood disorder characterized by monoclonal proliferation of small mature B lymphocytes. This is reflected as an elevated total white cell count and lymphocyte count in peripheral blood. NCCN criteria requires the monoclonal B cells to be above 5,000 per microliter to be called as CLL. Many times, elevated lymphocyte count on a routine blood test is what that leads to the eventual diagnosis. Some patients present with enlarged lymph nodes. When the presentation is mostly as enlarged lymph nodes, the disease is called small lymphocytic lymphoma. If monoclonal B cells are less than 5,000 per microliter, the condition is called monoclonal B cell lymphocytosis. CLL is the most common leukemia in the Western world. Asian countries have lower reported incidence than the West. The male to female ratio is skewing towards a higher male incidence with 1.7 to 1, and the median age of diagnosis is 70. In the US, 30% of all leukemias are CLL. Genetic rather than environmental factors are likely to be responsible for the variation in incidence. Japanese natives and Japanese migrants, for example, in Hawaii, have similar instances of CLL as the people in Japan. In US, Caucasians have a higher incidence than African Americans, who in turn have a higher incidence than the Asians. Etiology and pathophysiology. No definite cause associations have been found. It's thought that CLL develops from post-germinal B cells. These cells have developed mechanisms of evading apoptosis and also have lost capacity to differentiate terminally. The normal counterpart of BCLL are thought to be the CD5 positive B cells seen in the mantle zone of lymph nodes, peripheral blood, and fetal liver. These CD5 positive B cells are post-germinal, self-reactive cells that are thought to be autoreactive and make autoreactive antibodies. There is considerable homology in sequence of IgV regions of the CD5 positive B cells that make autoantibodies and CLLs that also make autoantibodies. Overexpression of proto-oncogene BCL2 and other mutations confer anti-apoptotic properties. The diagnostic tests include clinical examination, blood tests which include full blood count, liver function, renal function, a Coombs test or direct anti-human globulin test, LDH and beta-2 microglobulin. Immunophenotyping to study the lymphocytes in closer detail and to ascertain the CLL score, and radiological investigation are also necessary. On clinical examination, most commonly enlarged lymph nodes, spleen or liver are found. Full blood count helps to assess the extent to which bone marrow reserves are compromised. Coombs test helps to rule out an associated hemolytic anemia, which is well documented and fairly common to be associated with CLL. Immunophenotyping looks at the surface antigen expression of the patient's lymphocytes. CLL score comprises of 5 salient features, which include CD5 expression, CD23 expression, weak or absent FMC7 expression, weak expression of surface immunoglobulin, and weak CD79B expression on the lymphocytes. A higher score is more likely to be CLL than a low score. Differential diagnoses include mantle cell lymphoma, prolymphocytic leukemia, splenic marginal zone lymphoma, and follicular lymphoma, to name some. Prognostication depends on the clinical and laboratory parameters. Older systems of prognostication have incorporated basic clinical and laboratory features, and include RAI and Binet staging, which are the most popular ones. Newer prognostic models have been developed that incorporate karyotype and other molecular studies. Adverse features include deletion of p53, an unmutated IGVH gene, ZAP70 positivity, and CD38 positivity. Many large studies have validated the older models. There are no data to indicate that patients with adverse chromosome features would benefit from early intervention. On the left side, revised RAI staging, which is common and popular in the US, classifies CLL as 5 groups, starting at RAI 0 and ending at RAI 5. RAI 0 is the earliest phase where CLL is manifested as just increase in lymphocyte count, and RAI 1 where there are palpable lymph nodes associated with the high white cells. RAI 2 where they also have associated enlargement in the liver or spleen. RAI 3 where there is lymphocytosis and anemia, where anemia is defined as hemoglobin less than 11 gram per deciliter. And RAI 4 where there is lymphocytosis which is combined with thrombocytopenia, where thrombocytopenia is defined as a platelet count less than 100,000 per millimeter cube. On the right side, Binet staging, which is popular in the Europe, start with Binet stage A, where the hemoglobin and platelet count are adequate, and as seen defined as hemoglobin about 10 gram per deciliter and a platelet count more than 100,000 per millimeter cube, and less than 3 affected lymph nodes. On one extreme, and Binet stage C, where the hemoglobin is less than 10 gram per deciliter or platelet count is less than 100,000 per millimeter cube, and a Binet stage B in between, where there is more than 3 lymph nodes, and the patient belongs to stage A otherwise. They basically go from a stage of pure lymphocytosis to the extreme where the lymphocyte count has affected the bone marrow reserves, where they become stage 4 by RAI or Binet stage C. Asymptomatic CLL patients do not need treatment. If they need treatment, the treatment of choice would be using fludarabine-based therapy. Indications for starting treatment include presence of systemic symptoms, example, fever, weight loss, etc. A rapid lymphocyte doubling time, which is defined as doubling a lymphocyte count in less than 6 months, or presence of painful lymphadenopathy or splenomegaly. Patients who have disease coming back in less than 6 months of initial treatment are termed refractory CLL. If the disease relapses after 6 months from the initial treatment, the term progressive disease is used. Refractory patients are ideally treated on clinical trial protocols or considered for bone marrow transplantation if eligible. Progressive disease may be treated with the same chemotherapy or newer trial protocols. Examples of agents used in such settings include bendamustine, alemtuzumab, ofatumumab, etc.